Good afternoon and a very warm welcome to respected faculty and dear colleagues. My topic for discussion today is fever in a neutropenic patient. My SR preceptor is Dr. Vishak. My gratitude to Dr. Piyush Ranjan, Dr. Rishi Dhawan, and Dr. Deepam Pushpam for guiding me, and special thanks to Dr. Tejaswini for helping me out with the slides. Febrile neutropenia is an important topic to be discussed in our setting, as in the absence of antibiotics, it carries around a 70% mortality, but even after antibiotics, the mortality is 36 to 45%. Also, in a neutropenic patient, fever may be the only indication of an infection, as the signs and symptoms are typically attenuated. Hopefully, this seminar will provide clarity on the diagnosis and management of the same. So we have a case of a 23-year-old gentleman who's recently been diagnosed with AML. There was no evidence of infection at baseline, and baseline blood work showed a hemoglobin of 7, a total count of 13,000 with 96% blast and 1% neutral, and a platelet of 20,000. So he was started in prophylactic levofloxacin, acyclovir, and posaconazole, and given 3 days of daunorubicin and 7 days of cytarabine therapy. On day 8, he is found to have an ANC, or an absolute neutrophil count, of 60 and an oral temperature of 1 or 2 degrees Fahrenheit. So, in a sense, this is a patient of a hematological malignancy now presenting with fever and neutropenia. But does he satisfy the criteria for being called as febrile neutropenia? In order to do that, we will have to look at the definitions. So, the fever in febrile neutropenia is defined as a single oral temperature measured as more than 101 degrees Fahrenheit or a temperature of more than 100.4 degrees Fahrenheit, which is sustained over a 1-hour period. In these cases, axillary temperatures are not accurate and rectal temperatures are actually avoided to prevent translocation of resident flora. Now, coming to neutropenia, neutropenia is defined as an ANC, an absolute neutrophil count of less than 500, or one which is expected to decrease to less than 500 over the next 48 hours. Profound neutropenia is an entity where the ANC is less than 100, and functional neutropenia is important in settings of hematological malignancies where the number per se might be normal, but there is a functional defect in the neutrophils like impaired phagocytosis and killing of pathogens, which again contributes to neutropenia. So does our patient have febrile neutropenia? Yes, because the fever is more than 101, 102 in this case, and the ANC is obviously less than 500. In fact, it is even less than 100. So we can say that our patient is having febrile neutropenia and profound neutropenia. Now, what are the broad causes of neutropenia? Very importantly, the 3 causes that are being discussed, that will be discussed in our seminar and features in most of the guidelines as well, include the chemotherapeutic agents causing bone marrow suppression, bone marrow ablation prior to transplantation, and hematological malignancies. Apart from that, we have to keep our radars open and understand that there are other causes of neutropenia which we commonly see in our wards. Things like post-infectious neutropenia, nutritional causes, autoimmune, hypersplenism, drug-induced bone marrow failure. There are also a few congenital causes of neutropenia as well. So, back to our case, why exactly does he have neutropenia? This is the most common cause of neutropenia, which is the oncological cause. This might be due to bone marrow infiltration by malignant cells or chemotherapy-induced marrow suppression. Chemotherapy-induced febrile neutropenia is seen most commonly in hematological malignancies in as high as more than 80% of cases. It's a bit less common in solid tumors, 10 to 50% of cases. So why is our patient running a fever? In order to understand that, we have to understand the normal functioning of a neutrophil. So neutrophil is derived from a myeloid progenitor cell, which also gives rise to the erythrocytes and the megakaryocytes. A neutrophil is the first line of defense against the invading pathogens, and they perform this function by virtue of phagocytosis by the primary and secondary granules and something called nets or neutrophil extracellular traps. So in the setting of acquired or congenital conditions causing neutropenia or medications which might be suppressing the bone marrow, the neutropenia by virtue of reduced phagocytosis and reduced production of inflammatory mediators predisposes the host to a variety of infections like UTI, pneumonia, mostly of bacterial or fungal etiology, but may also cause reactivation of dormant viral infections. We also need to understand how chemotherapy contributes to febrile neutropenia. So not only does cytotoxic chemotherapy end up suppressing the bone marrow, what it also does is simultaneously it causes GI mucosal injury, and this loss of barrier helps in the resident microflora to simply translocate across, and this forms the pathogenesis of febrile neutropenia. Also, such patients typically have indwelling catheters which provide them easy access to the bloodstream. We have explained the same in this diagram here, where just after chemotherapy there is simultaneous neutropenia, as you see, and mucositis causing bacteremia and subsequent infections. Here we'll be talking about neutropenia in those patients whose bone marrow has been ablated prior to stem cell transplantation. This is the Rubinstein scale where you can see that the phases are pre-engraftment, post-engraftment, and late phases. We are mostly concerned with the pre-engraftment phase, where, as you can see, the recipient's bone marrow has been ablated, putting him at a higher risk of infection with gram-negative bacilli like Pseudomonas acinetobacter, which are commonly seen in our settings, gram-positive organisms like coagulase-negative staph, viridin streptococci, and in some cases MRSA as well. Viral infections like HSV, other respiratory and enteric viruses, fungi, most commonly seen by Aspergillus candida and Mucor. But the issue remains that no infectious etiology is documented in most patients. Only in 20 to 30% patients do we have an offending organism. Bacteria is seen in 10 to 25% of patients, and the common sites of infection are given here in order of frequency. Here we shall discuss the changing etiology of bacteremia. In the 60s and 70s, as you can see, the gram-negative infections were more common, but in the 80s, there was dominance of gram-positive infections. This is most likely due to the more intensive chemotherapy causing more mucositis, the increased prevalence of indwelling catheters, and prophylaxis by fluoroquinolones. But again, we are seeing that there has been a gram-negative resurgence. So there's been an emergence of antibiotic resistance gram-negative organisms, typically the MDR strains, and the international data suggests that gram-positive to gram-negative ratio is still around 60s to 40, and polymicrobial infections are on the rise. The Indian data, however, is a bit different. This is a paper by our own institute. This has reported that gram-negatives were dominant. It was seen in around 73% of cases, with Acinetobacter being the most common offending organism, and it also reported a very high resistance to antibiotics. There have been a few other papers here too. The gram-negative isolates were more common, and here 44-46 seems to be the ratio of gram-positive and gram-negative organisms, but note here that gram-negative bacteremia is associated with a higher mortality. Now, coming to prophylaxis, so whether a patient will need prophylaxis or not basically depends on whether the patient is high risk or low risk. We will discuss the risk stratification further down the line. For now, just remember that low risk patients do not need antibiotic prophylaxis, but in cases of high risk, we usually provide prophylaxis with fluoroquinolones, and levofloxacin is commonly used. A word of caution here, it has been shown that levofloxacin prophylaxis may be contributing to antimicrobial resistance. We have to be cautious because if the community resistance for fluoroquinolones increases 20%, then we will lose the drug in this setting. Regarding antifungal prophylaxis, antifungals may be anti-yeast or anti-molds. Now, we will prescribe anti-yeast prophylaxis in the form of fluconazole to those patients who are mostly have acute leukemia in ALLs and the pre-engraftment phase, which recall that we showed the Rubinstein line in the pre-engraftment phase of HSCT recipients. Anti-mold prophylaxis is mostly indicated in those patients having AML with prior history of invasive aspergillosis or with profound and prolonged neutropenia, and in those patients with the post-engraftment GVHD on immunosuppressants. Antiviral prophylaxis, acyclovir prophylaxis is only to be given to those who are HSV seropositive. Mostly we have to think about vaccinating them. Annual influenza inactivated vaccine is recommended for all patients being treated for cancer, and the timing here is important. It's more than 7 days after the last treatment or more than 2 weeks before the chemotherapy starts. So now coming back to the original case of neutropenia with fever, few things to keep in mind. First off, febrile neutropenia is a medical emergency. We need to classify the risk of the patient. We need to understand whether it's high risk or low risk, because this will determine what type of empirical antibiotic therapy he gets, oral or IV, whether he'll be treated as an inpatient or an outpatient, and this will also guide the duration of antibiotic therapy. A number of validated scoring systems are used to estimate the risk, like Talcott rules, MASC score, and Cisne score. The IDSC guidelines of 2011 suggest using the MASC score for risk stratification, so we will be discussing that in detail. So this is the MASC score. As you can see, it includes the burden of illness, the comorbidities, the outpatient status of the patient, and the age as the criteria. It has a sensitivity and specificity of 95% each. But of course, the MASC score is not foolproof. The drawbacks of MASC score include the burden of illness. Now, this is a very subjective term and may vary between observers. So this is one of its drawbacks. The other thing is the duration of neutropenia is known to be a risk factor, but it does not even include it as a criteria. And lastly, the score was developed using heterogeneous patient population, and as a result, it has a low sensitivity, like 36% for solid organ tumors. But there's no need to remember complicated scoring systems. We might simply, on a day-to-day basis, do the risk stratification based on clinical criteria. The clinical criteria include high-risk patients to be classified as those who are expected to be neutropenic for more than 7 days and have ongoing comorbidities or evidence of significant hepatic or renal dysfunction. Similarly, low-risk patients are those who are expected to be severely neutropenic for less than or equal to 7 days and have no comorbidities or evidence of significant hepatic or renal dysfunction. Finally, those who are receiving chemotherapy for solid organ tumors are also usually classified as low risk. And coming to the comorbidities, which we discussed in each case, this is basically the list of comorbidities. It's a mental checklist that we could go through. Now coming to the investigations that are to be ordered, simply we will send the routine investigations that we usually do, CBC, LFT, KFT, electrolytes. Some words about the blood culture that's to be sent. So we have to send 2 sets of blood culture. One set comprises of 20 ml, 10 ml each in an aerobic and anaerobic culture bottle. And this set is to be drawn from the 2 lumens of a central venous axis if present, and 1 peripheral venous site, or if it is not present, then 2 separate peripheral venous sites. Then if we can find a focus of infection, we will send site-specific cultures and further imaging. So now we shall be discussing about the treatment protocols. So this is the algorithm from the IDSC guidelines. We have already discussed this. Let's just go over it once. So first we are finding out if the patient fits the clinical criteria for febrile neutropenia. Then we are calculating the MASC score and classifying it into high risk or low risk. So in all cases of high risk, there is no confusion. We have to start inpatient broad spectrum IV antibiotics. And in cases of low risk, this will depend on a case-to-case basis. It might be that we have to start inpatient oral antibiotic therapy in some cases and IV in some cases. So we will discuss each of these in turn. If the patient is low risk, then oral therapy and early discharge is the policy which is followed. We usually give Ciplox and Augmentin or levofloxacin monotherapy. If the patient is high risk, however, we have to start off the empirical IV antibiotics after blood cultures within 1 hour. This is the most important takeaway from this slide. What drug to give? So we're starting off monotherapy with anti-pseudomonal cover as in the form of beta-lactams, cephalosporins, carbapenems, or piptas. Remember that extended infusion of beta-lactam antibiotics have been found to have an increased efficacy. Addition of antibiotics like aminoglycosides, fluoroquinolones, this has specific indications, which are if the patient is hemodynamically unstable, if there is an evidence of pneumonia, if we are suspecting antimicrobial resistance, or there is a previous history of Pseudomonas aeruginosa colonization or invasive disease. Similarly, should we add gram-positive cover like vancomycin or targocid, which is commonly used in our setting? It is not recommended as a standard part of initial antibiotic regimen. Recall that even though the gram-positive rates have increased, we are still not recommending gram-positive cover outright because mortality is seen more with gram-negative organisms. Again, there are specific indications for when to start gram-positives. In these cases, these are suspected catheter infections, skin and soft tissue infections, severe pneumonia with shock, and severe mucositis. So this we have basically discussed. It's in a flowchart form. So we have assessed the risk, whether low or high risk. We have assessed whether we need to give oral or IV in cases of low risk. In case of high risk, there is no such dilemma. We have to start IV. We need to understand whether a gram-positive cover is needed outright or not based on the indications that we discussed. If it's needed, then we start it off with vancomycin plus the anti-pseudomonal cover. And if it's not needed, then whether monotherapy or dual drug therapy is needed will again depend on the indications that we discussed. Finally, we'll reassess this after 3 to 5 days. Now, coming to antifungal therapy, the antifungal therapy may be of many types actually. So first is we could be giving the antifungal as prophylaxis. Then if the patient mounts a fever, but we have no other indication of fungal disease, then we'll call it empirical antifungal therapy. Added to this, if we have a serological test like galactomannan positive or radiological evidence of fungal infection, in this case, we will call it preemptive therapy. Finally, if we have a tissue diagnosis or a culture positivity, that case we'll call it a specific or targeted therapy. So empirical antifungal therapy is given in high-risk patients. This will be indicated in case of persistent fever even after 4 to 7 days of empirical antibiotics. And preemptive approach, as we discussed, will be given if we have a clinical or radiological evidence of infection or a serological test like galactomannan. The choice of antifungal agent will depend on if we on whether we are suspecting an yeast or a mold infection and whether the patient was already on any antifungal prophylaxis. Now, if you're suspecting an yeast infection, most commonly albicans is the common colonizer, and we have to treat it with azole, commonly fluconazole. Keep in mind that some species like Cruzium glabrata are intrinsically resistant to fluconazole. In that case, we have to entertain the possibility of echinocandins. If you're suspecting mold infections, then aspergillosis is the most common, and the gold standard therapy in this case would be amphotericin B. The other options include voriconazole and echinocandins. Keep in mind that even though patients are being given mold active agents, some of them are still developing breakthrough invasive mold infections. So recall that in the previous flowchart, we had started the patient on IV empirical antibiotics and we had to reassess after 3 to 5 days. So what if the patient is improving? The decision to be taken now are regarding de-escalation of antibiotics and stopping of antibiotics. The guidelines in this scenario are the IDSA document of 2011, which said that the appropriate antibiotics had to be continued at least till the duration of neutropenia, that is until the ANC recovered. However, we have another theory which was given by the How Long study that said that the empirical antibiotic therapy can be discontinued after 72 hours of apyrexia and clinical improvement, irrespective of the neutrophil count. But what to do if the fever is not responding? So this basically forms the definition of persistent neutropenic fever, which said that fever will not respond despite empiric broad-spectrum antibiotic therapy after 5 days in case of high risk and 2 days in case of low risk neutropenia. So once we're reassessing after 3 to 5 days, if the microbiological diagnosis is made by then we have to modify it accordingly. If there's persistent hemodynamic instability, we have to start thinking about gram-positive covers or resistant gram-negative organisms. And as discussed, even if there's no response after 4 to 7 days, we add the antifungals. The same thing is now discussed in a flowchart. I will direct your attention here where they're discussing about how to start antifungal therapy, which we already discussed, and here where they are discussing about the need to add gram-positive covers and to broaden the antimicrobial coverage. Finally, about antiviral therapy. So there's no role of empirical antiviral treatment. Influenza should be treated with neuraminidase inhibitors, and treatment is indicated if there is evidence of active disease. Next, what is the role of growth factors? So myeloid growth factors or recombinant colony stimulating factors or CSFs, they stimulate the hematopoietic progenitor cells. We are typically using filgrastim and pegfilgrastim in our setting. Primary prophylaxis with CSFs is indicated in anticipated risk of febrile neutropenia more than 20%, and this is usually initiated after the first cycle of chemotherapy to prevent neutropenic complications. Similarly, secondary prophylaxis is indicated where there is febrile neutropenia in prior chemotherapy cycle, and it has been shown to reduce the risk of subsequent complications by 50%. So we understand that there is a role of colony stimulating factors in prophylaxis. However, there is no therapeutic use of CSFs, and actually IDSA recommends against this use. Adverse effects of CSF include musculoskeletal pain, allergic reaction, flu-like symptoms. Also understand that in a setting of a myeloid neoplasm, it may actually end up stimulating the neoplasm. Granulocyte transfusions usually are obsolete now. The main limitation is collection and storage of adequate doses of granulocytes. Daily transfusions may be required to elicit significant response. A meta-analysis in 2015 said that there was a no all-cause mortality benefit. However, there is reduced risk of bacteremia and fungemia. Apart from this, prevention of infections in neutropenia may be achieved by hand hygiene, strict barrier precautions, laminar flow 12 air exchanges per hour, and isolation of transplant recipients. Thank you so much.